So welcome to the webinar, iTero Digital Workflow for Partially and Fully Edentulous Scanning. And with that, it is my distinct pleasure to introduce tonight's speakers. First up is Kelly Bevington, RDA EFDA Director of iOS Technology. Kelly began her career more than 20 years ago as an RDA EFDA, graduating from Bryman College. She has a comprehensive knowledge of dentistry and the dental laboratory industry. Kelly has been professionally trained on most major devices, and she is able to provide expert chairside coaching. She manages the NDX clinical iOS training team and has clinically trained over 1,000 dentists and their teams. Kelly enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. I'm Brittany Carey, RDH, iOS Clinical Training Specialist. Brittany is a registered dental hygienist and an experienced intraoral scanner trainer, having trained hundreds of dental professionals throughout the West Coast. Brittany has a passion for training and education, and her ultimate goals are to share effective scanning practices, promote patient education, and to create success for every dental team member. Brittany resides in Phoenix, Arizona, in case you want her to come out and visit you. And with that, it is my pleasure to turn it over to you ladies. Take it away and have amazing training.
Thanks so much, Jessica. You're the best. I'm going to reiterate something that Jessica said, and that is to thank you all for being here. Truly, we realize that you've got lots of different training opportunities and ways to spend your evening, and the fact that you're choosing to spend it with us to learn more about how to scan partially and fully edentulous cases with iTero scanners it warms our heart, makes us happy. This is what we love to do. So we do have a training team at NDX. It's myself, Brenda Kirkin, and Brittany. So Brittany and I are going to be doing the iTero presentation tonight. A little bit about our course overview, rather. And what it's really about tonight is scanning the partially and fully edentulous patient, and just the evolution that has occurred really over the last year, 2 years. I mean, 5 years ago, this wasn't even really considered an option to be able to do, and how best to communicate it to the laboratory. As the lab, we have, opinions and ways in which we've experienced the best success, and that's what we want to be able to share with you. So we're going to talk about different types of cases, how best to identify if you've captured the necessary anatomy that's needed for these types of cases, anatomical landmarks, and the best way to view after post-processing to prepare your final RX for the lab. So I'm going to start with something that we get questions about frequently, and I will tell you pretty much every lab technician has a slightly different opinion about how best to take a scan for a crown under an existing partial. So we sort of queried the different laboratories and spoke to some different dentists, and these are the 3 top ways to achieve it that we have been able to identify. So the nice thing with the iTero scanner is it has a pre-treatment option. There is a pre-treatment tab directly under restorative when you're selecting your type of case on the RX screen. And you want to make sure that you're selecting that pre-treatment box while you're doing the actual RX. Once you move off the RX screen, you're unable to go backwards and do the pre-treatment. So with 2 different ways to do the pre-treatment, one would be taking a scan without the partial in the mouth of the existing dentition that the crowns and adjacent teeth fit into the partial. Now, if the tooth that you're going to make the crown on is directly involved with a clasp or a rest seat of that partial, it's going to be critically important to capture that tooth, right? If it is broken down, and that's part of the reason as to why you're doing a crown on it, I might encourage you to build it up slightly with some composite material, tack it, fit the partial into place as you're tacking it, and then take the scan of those pre-existing teeth. The other pre-treatment would be done at the end of the procedure. So it's pre-treatment, you're still selecting pre-treatment, but you're not going to actually take the scan until the end, where you're fitting the existing partial to temporaries that you're making right then and there on the spot. So two different ways to do the pre-treatment. Both are taken with the partial out of the mouth, but both are taken with the crown portion of the tooth built up to accept a clasp or a rest seat of an existing partial. And then the additional option is not using pre-treatment, but it's taking a scan, an operative scan with the partial in place. And it's only going to be designed specifically for the a partial that would be cast frame, not an acrylic partial. That truly is my least favorite. I have never been able to successfully scan the crown prep and the intaglio of a cast metal partial clasp at the same time. And that's what would need to be achieved in order to have that option work for you. If you have any particular questions on the partials or would like some one-on-one kind of conversation or training with us on it, by all means, feel free to reach out to us. Now, when it comes to a digital workflow specifically for the fully edentulous patient, that's what we're going to spend most of the focus on tonight. And so our three different types of digital denture workflows are going to be a copy denture, a reference denture, or an immediate denture. The copy denture is exactly that. It is pretty much an exact copy of an existing denture. It can be altered slightly. The tooth shade, of course, can be altered, but it's really a copy of an existing denture. And I know I've said this a million times now. My teammates are getting tired of me saying it, but I've been in dentistry my entire adult life, and I've never had a patient come in and say, I would like a copy of this exact denture. I just haven't had it. I'm sure it happens somewhere because we do make them, but it's a small percentage. Then the reference denture is what we're really going to spend a lot of time on. And it is an existing denture. It's a patient that has an existing denture, and it has to meet some requirements, some prerequisites, and we're going to review what those are. But we're going to use that as a template for constructing the new prostheses. It will be the custom tray. It is the best custom tray you could ever have, the existing denture of a patient. And that we will take a wash impression inside of. And then we have the immediate denture. Immediate denture have had fantastic success. It's really pretty easy to scan. As long as the patient has some existing dentition, it makes it much easier for the acquisition of the data. You have an occlusal surface somewhere to initially capture and start that scanning process. And it's potentially a 2-appointment, it is a 2-appointment procedure, and it works out really, really well. So I wanted to review just a little bit for what the digital dentures look like, right? What these printed dentures look like. And so this is an example of a printed denture and a printed functional Tri-N. And I think you'll find the process really pretty interesting. Go to the next here. So this is that functional try-in that we talk about. The first time I saw one in a case box, I was like, whoa, okay, that took me back a little bit. I wasn't expecting it to be all tooth colored, right? Monochromatic, if you will. So it's printed and it is all one shade. You're still able to use it as a try-in and communicate back to the lab, whether perhaps you want to shift the midline, you want to rotate a lateral, you want to, expand the buccal corridors. I mean, you can still do a lot of alterations at that point. Not a lot, but some alterations at that point. You can check the occlusion, of course, and you're going to send those back to the laboratory. What's interesting, or what I think is interesting about this process, and I would not tell the patient this ahead of time, but ultimately upon delivery of the final denture, you could indeed provide this to the patient as a value-added service as an emergency denture, right? It's that emergency denture. And I think that, would help to differentiate you in the community as well. And so this is an example of some different images off of the 3Shape software that we use to design the dentures at the laboratory itself. So this is a design of an upper and lower denture, right? This is an example of the border molding technique that occurs. You can see all the little blue dots, right? When Brittany does the live wash impression reference denture technique, you will notice that on our impression material, we really needed like a Bard Parker or a scalpel to help trim back that impression material. So that's going to be really important for you to do with the reference technique. And then this is what the model looks like at the lab in the 3Shape software. This is an actual live case, by the way. I thought it would be important for people to see that and experience that. And so this is the setting of the teeth, both from a face forward as well as a buccal view. So we've got the maxillary denture, the mandibular denture, and then the one in the center where it's the two together. You can see the stippling that has been designed into the print during the design part in 3Shape. And so this is some of the manufacturing process that I'm imagining most people aren't very aware of, right? So this is what they come out of the printing machine looking like. So you can see all the bases here, right? You can see the maxillary bases. And then these are the teeth themselves. So the base is printed separately from the teeth, and then they're going to merge it together. I see I have a couple questions here. So I'm going to speak to them before I get into the process part and do it live. Can you review how to scan any Edentulous case, both for an RPD and a complete denture? We are going to scan for a complete denture, and you're really going for an RPD, the process is going to be as you would do a full arch scan. And in the scanner, there is an option to select RPD. Let's see, can the lab make a PMMA immediate denture with gingival base so that I can use it for probably. I think it would be case specific and lab specific, but I think doing a temporary denture from a scan is absolutely possible. So copier reference denture, right, is the scan of the denture, taking the bite registration, doing the design in CAD/CAM, providing that functional try-in that we saw, right, the printed functional try-in. And if you need to take a wash impression or redesign, you could send it back to the laboratory, and then they would send it back to you for insertion. So with a copy or a reference denture, the most common steps is going to be a 3-step process where you would take the scan of the patient's existing denture for a copy, or the wash impression inside of an existing denture, opposings, bite registrations. Your second appointment would be a try-in. It would be the functional try-in. Providing that is a good try-in, then it would go to finish. If it's not a great try-in and you want some adjustments at that point, you would do a wash impression, or you would communicate to the lab something about the positioning of the teeth that you want to change, and then you would potentially do another try-in. With the immediate denture, it's going to depend a little bit about what the opposing teeth are, whether you can achieve a good solid bite registration, which is a challenge sometimes with the immediate denture patient. Oftentimes they don't have a full complement of teeth to get a good accurate bite registration. Your second appointment would not really be, right? Like if you're going to do some sort of bite blocks, you could potentially, depending upon which teeth are missing, but more often than not, it's going to be immediate. So you're going to get that denture back. And if needed, you could do a wash impression and another try-in if you need to. Got a question here. Are you going to scan the wash impression? Yes, we are going to scan the wash impression. With the reference denture, you do not need to scan the soft tissue at all. That is correct. I think that was a question, but I'll make that as a statement. Okay, so it's reviewing the steps for the reference denture. It's the scan. It's getting all of your traditional records. It's us then in the yellow is the lab, right? Reviewing in CAD, doing the design, providing the printed denture try-in for you. So blue is back to the in-office with patient. And then depending upon whether you need adjustments or not is going to depend upon what additional steps there would be at the lab. But then you would go to finish polish and return for insertion. So the 3D workflow really provides a seamless utilization of techniques, right? And really digitizing everything. Once we have several doctors and several labs that once they really get the process down and understand clearly the anatomical landmarks that are necessary, it's necessary to have a dry intraoral cavity when you're doing some of these intraoral scans, whether it be for the partially or fully edentulous patient. People are going directly to finish. So they're doing a try or they're doing a scan. They're feeling confident with try-ins that they have received in the past, its level of accuracy. And so they feel confident in going directly to a finish. I'm a try-in person, so I would like to do the try-in, but know that there are people that are going past that step now. Got a question here. How do you recommend getting a bite registration without a record base and wax rims? So that's a great question. If your patient is fully edentulous, let me answer this live. If your patient is fully edentulous, we as a laboratory are promoting the immediate denture, reference denture, and copy denture technique. So if the patient does not have any existing dentition at all, that's not necessarily what we're promoting. And we still accept those files, but know that your scan of the edentulous patient intraorally can oftentimes be limited as far as its accuracy. So when you are retracting the lips and cheeks, you are changing the vestibular muscles so that although you might be acquiring that data, that information of the tissue, it might not be an accurate representation of what the patient needs for a good fitting denture, because a denture fits when your lips are at rest, right? So when you're retracted and that's your, quote unquote impression, it's different than when the lips are at rest. So that's why we really promote the reference denture technique, which requires the wash impression, right? So that's why we prefer the reference denture. And it's going to take a little bit of time, right? So it's going to be more time than what you would traditionally do. The other thing with the fully edentulous patient in trying to get those scans and how do you best record all of the records, right? I mean, people have papillometers and allometers and the conometer, and they'll do a mush putty bite. And most laboratories sort of cringe at the mush putty bite. They haven't had a lot of great experience with it being accurate. Now it might be, right? So it's very patient specific and clinician specific as far as how accurate that information might be. So when we're doing a reference denture technique, it's really evaluating the existing denture that they have. You can remove any existing liners, adhesives, anything that's inside of the denture. You want to remove it and make sure it's very nice and clean. You can use tray adhesive on the inside of the denture. Typically, isopropyl alcohol removes it well, depending upon what that denture was made from originally, of course. You can do border molding with PVS material. You can take your wash impression. And when I say border molding, I mean, you're doing the AIOU, you're having them go through those movements to get a real accurate border mold. And your traditional denture techniques, you're going to want to follow at that stage. Now, I said that we would review what is an adequate denture to use for a reference denture. So this reviews this a little bit. You don't want the denture to be broken. You don't want it to be missing teeth. Regular occlusal wear is fine. The border should not be overextended or underextended too much, right? And you want it to be pretty stable when the impression material is in place. You want it to be covering the retromolar pads, the hamular notch, the midline. If it isn't spot on, you want to make sure that you're communicating that back to the lab is something that you want changed in the future. And here is some visuals for you as far as an adequate reference denture.
We've got some people sharing their experiences in the chat.
Yeah, that's very cool.
I think is awesome.
Yeah, that's amazing. So for any of you that are not reading the chat, I would encourage you to read the chat. They started off with questions that I was answering, but now they're sort of sharing their individual experiences. And Brittany, I'm going to ask you to read those and call to our attention anything that you really want to make certain the whole, all the attendees know. What scanner, in your opinion, is the best for recording tissues? I use iTero. That's a good question. They're all a little bit different. And I have not personally scanned with all the different scanners, the fully edentulous patient. I will tell you, it's a little challenging, right? Like we've been taught to go fast, 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 right? It's speed, it's efficiency when we're scanning full arch scans for appliances or crowns, bridges, everything. And with removables, it's take a nice big deep breath and go slow. And it's hard. It's a shift in mindset, right? And it's important that you are aware of that so that you can set expectations for your team, for yourself. Know that with iTero specifically, it does not capture color per se. It is capturing topography, so all the little lumps and bumps and so forth. And there are some little tricks that we have tried using as far as placing like flowable composite, which will provide a 3D reference, right? So that can be a good thing. Early on, I was using Dr. Thompson sticks and making like little X's on the palette, not for the scanner, but for my eyeballs, for my brain to sort of have a path to follow, to be methodical. You need, iTero specifically needs a point of reference to continue stitching that model. So it's important that you go in a very methodical pattern. And these are continue to be examples of the clinical assessment to determine if a denture is appropriate for a reference denture wash impression. So this is an image of what the actual border molding looks like in this particular case. Please read the whole question. Okay, please read the whole question before you give your answer. I think you can see the question too, but I might not know that for sure. So thank you. I will be sure to read the whole question. So this is an example of border molding. It's important to trim that excess. We talked about that a little bit earlier. A Bard Parker scalpel will do fine with that. You'll notice that the reference denture, the wash impression that is already in the denture that Brittany is going to scan here momentarily is not trimmed, and you'll be able to see that difference. It works much better if it is trimmed. And this is what I mentioned about applying a little tray adhesive if needed. And then this is the bite registration. So a little bit of bite material was placed between the maxillary and mandibular dentures to secure them in place. We have found that oftentimes with that fully edentulous patient that is currently wearing dentures, when you have them closed, they tend to slide. It's hard for them to stay in place right where we want them. So as the clinician, you can have them occlude and put material to secure the interocclusal registration prior to actually scanning. Great. Functional try-in. So this is a printed functional try-in. It is sent home with the patient, so they get to experience it. They can, laugh, they can check the lip line and so forth. You then can mark, adjust, add or reduce information as you need it, and potentially do a wash impression in it if it needs it before sending back to the laboratory. Just another example of the wash impressions inside of the existing dentures. And then this is the iTero RX. And before I go to the RX, I am going to check the chat here, see if there's any additional questions here. Scroll up a bit. A copy denture could be an upsell at the time of pickup as a second denture instead of single. I will scan a new denture into the patient's file just in case they lose it. or for a nursing home scenario. That's a really great idea. Love that. I love that. I have used Blue Cam spray from the original CEREC scanner to make the denture almost matte-like, and it works well, although it can rub off. I agree, Melanie. I have used different types of titanium dioxide materials, and it can be very helpful to create that matte finish. It can also make it sort of slippery when you're wearing gloves, so just be cautious of that. Did you deliberately not put PVS on the middle of the palette? Yeah, that was just showing the border molding. So yes, there would be a little bit of the light body PVS material on the intaglio of the denture prior to scanning. Are there any tips to scan a denture? Scanner has a hard time scanning acrylic and teeth. The greatest tip I have, and we're going to review this live, is to go slow, be still, only move the hand that the scanner wand is in. You're going to hold the denture very still, and make sure that there is no reflective light, right? So if you have blinds in your operatory, please turn them off. Make sure that the overhead light of the chair is off. Any kind of reflection you want to make sure is removed. Okay, we're asking about raising hands. If folks are sharing ideas, they need to check the box, everyone. Thank you. Thank you, Bern Weber. Appreciate that comment. What iTero version and software?
We do have a couple, yeah, we do have a couple more questions, but I feel like we should save them because I want to make sure we have enough time for the demonstration.
Yeah, absolutely.
And we are going to have a time to address those while we wait for the software to.
Yeah, some of the software has to post-process and it's going to chug along a little bit.
Yeah.
So I will go back to question and answers then. So this is an example of the RX. Something that is a little different here just over the last 6 months is the option to select removables and then what type of a removable prosthesis it is you're looking to have made. So it's going to ask you what stage you want to move forward with, and you can select whichever stage you want. Know that the laboratory may comment back to you that they needed additional information, you know, like worst case scenario, maybe they want to provide you a custom tray, for instance. Type, partial, immediate, full tissue, or full implant is what you would see on the RX. And then it does give you much greater detail than it ever did before as far as molds, the shape of the patient's face, good things like that. So this is the scan path protocol, and this is part of your handout as well. This is specifically from iTero. So this next information is specifically from iTero. Okay. Step 2 is going to be to get the palate. Step 3 is the buccal corridors, then the bilateral flanges, and last is going to be the intaglio. This is an actual scan of a maxillary denture with the iTero, a mandibular denture with the iTero, a real case bite registration. This is an example of a wash impression, and that is the actual wash impression that Brittany is going to scan tonight. This is a live case maxillary wash impression, mandibular wash impression, and the bite registration together. This is going into the 2-step process for an immediate. We're going to make sure that we have adequate anatomical landmarks, and these are real cases. missing information, right? We really need those buccal vestibules, critically important. I'm not going to go through all of this. Keep it dry and go slow. Four-handed dentistry is really probably needed so that somebody can very gently be retracting the lips and cheeks while the other is scanning. And this is for the fully edentulous patient. And I wish we had a fully edentulous patient that we could work with. And so I want to put it out there to all of the attendees. Any collaboration with an active, fully edentulous patient that you would like to work with us together on, documenting some of these steps, we're all ears. We think that would be a wonderful thing to accomplish and how to educate people. This is a screenshot feature that is on the iTero. So you could, in essence, take a screenshot of something that you see on the screen. This is that wash impression. And I'm communicating back to the lab that I want to shift that midline. It's a really neat tool as well. And then these are some resource pieces that were part of your handouts that you received earlier. And this is us, right? So this is an email address and an 800 telephone number if you want to schedule any kind of additional information, training, or so forth with us. And I want to provide Brittany an opportunity to do the live scan. So I'm going to escape this and stop sharing. So you can share, Brittany.
Awesome. Thank you.
You are welcome. I chatted too much. I went over a little bit, so sorry about that.
It's easy to do. There's so much information, and we wish we could go over every scenario in depth. It's tough. I just want to confirm you can see my screen, my iTero screen.
Yes.
Perfect. Okay, so I am starting from the RX. You can see I have this pretty purple banner here. If you have any questions about this in particular, please contact iTero directly, as it really doesn't have anything to do with what we're talking about tonight. So I'm going to go down here to procedure. Can I move this? I sure can.
Yeah.
We're going to go to denture removable, of course. I did see someone in the chat say that once you select this, that the software should automatically turn off or disable AI cleanup.
Yes.
That has not been the case in my experience, unfortunately. So I always make sure that I double check. Again, here are the options to select from, but for the reference denture demonstration tonight, we are doing full denture tissue based. I love this option right here. Send to my iTero account only. That's great for copy dentures if you have a denture and you want to scan it. I believe it might have been Lynn that said that in the chat, just so they have it on file. I'm going to select stage try-in, random tooth shade, upper denture. I'm not even going to pick that, even though you should pick something. And then, of course, any other additional information that you want the lab to know, super important that you include it here. Now, as Kelly had said, this is not easy. In fact, in all of my trainings, I call this the Olympic sport of scanning because it is. So be patient with yourselves, with your scanner, with your team. It's going to have me scan the lower first, and I am going to stay on camera and just scan this here. So again, Same scan path protocol as always, occlusal lingual buccal. In the viewfinder window, I always like to point out the angulation that I have going on, because the lens can see exactly how tall the teeth are. I'm going to rotate to the buccal on the opposite side. To the midline, roll over that incisal edge for good measure. I'm going to go ahead and hit the blue arrow. We're going to scan the denture with the pickup impression. I don't know if you can see that. Let me know if you can't hear me, okay? But I want to show you how I hold it, which is very still. You have to hold it still in your non-dominant hand and only make sure that you're manipulating the inner wand. Oh. See, I'm going to disable AI cleanup. And start all over. So what we want to do here is one, that our fingers are on the right. But what we want
Oh, Brittany, if you could do a little louder.
Oh, okay.
Thanks.
We want the scanner to be able to identify the outline of the entire model. And then it seems to have an easier time capturing everything else in between. So I start with all occlusal. I get that border molding, which needs to be trimmed. It's not trimmed, obviously. What I'm going to do now is I'm going to rotate lingual and just kind of pivot. And you can see the light from the lens reflecting off of this smooth palette. So it can cause distortion. So it's just important to take your time. Can you see my hands okay?
Yeah.
Great.
Notice it's only the wand that's moving. She's not moving her left hand that's holding the denture. And that's a common error that we see with folks.
Right. And what ends up happening when we do that is the scanner starts thinking that we're scanning two different things. So you're going to start seeing duplicate arches and things like that. Like you can even see on the palette, it's having a hard time stitching together the middle of the palette. So what I'm going to do is kind of show it something it knows. Kind of bring it down. Now it thinks the green is somewhere else. So we're going to set it straight. Now without turning the scanner off, this can become ugly very quickly. So to fix this, again, I'm going to show it something it knows. Show it that the green symbol is right here. Thank you, NDX Green, for providing me this model. Shout out to them. Okay, we take it away. See if it can't fix itself.
And you're allowing the processing to occur.
Yes.
Yeah.
Oh, that's so ugly. Well, while it's kind of thinking about it, I'm just going to continue on. I'm going to roll buccally. And again, it captures teeth a lot easier than anything else. So we're going to give it the baseline of the teeth. Again.
So I actually noticed that on our, and I have the same sample denture that has, just like you might have the patient's name input to the palette, we have the laboratory name put into the palette, and I find that when I scan over that, it's not a great experience. There's additional reflection that occurs from that white label that's inside of the cameo section of the palette itself.
Okay, I give up on that part. So now what we're gonna do is I'm gonna go back to the buccal surface, but I'm gonna kind of do a wave so that I can capture the border molding. Because again, we're making a 3D model of this denture.
And notice how she's capturing the border molded material as well as the denture teeth at the same time in this wave motion. That part is important when you end up merging the acrylic portion of the cameo of the denture to the wash impression on the intaglio.
Exactly. Let's do that. Let's go. Let's go. Okay. Very slowly. Like so slowly. Now the same thing applies is we want to get a good outline of the entire model, and then it has an easier time stitching everything else in. Slow, so slow. And you can expect your scanner or the iTero to lose itself pretty frequently.
I'm sorry, Brittany, could you repeat that?
Sorry, I was gonna say, you can expect your scanner to lose you repeatedly in this process. So just be patient.
Yeah.
Go back and show it something that it knows, so it can find you again. Okay. Ever so slowly. All right. We made it. Now, now we can do everything else.
There you go. Now we're going to do the intaglio.
Okay. Show it something now. Maybe like a corner. All right.
Terrific. While you're picking up that data, there was a question that on the RX, there is a copy denture selection. And when might you use that? So I typed that in as a live answer. That would be for the copy denture prostheses, right? That workflow, that there is no wash impression involved and you want an exact copy of what the patient has walked into your office with. So you could change the shade of the teeth. You could make minor alterations, but the intaglio surface is really going to be an exact copy. So that's when you would select copy denture on the iTero RX. Look at you go.
Oh, no. Okay. I'm trying to have it find me, and it's struggling. This
Yeah, I'm glad you used the word find me, because remember with iTero, it is always looking for a point of reference to reconnect with, to continue building that digital model that we see on the screen. So it needs that. It continuously needs to see something that it recognizes that you have scanned in the past at that exact same angulation. While you're scanning, I'm going to answer another question. What happens when scanning a tooth or an area and it doesn't capture the scanned area and it doesn't show up in blue? It looks see-through. Is it important to rescan, or does the lab fudge the image to fill in the clear area? I've tried to rescan, but it doesn't fill in, and I hope that the lab can work with it. I would presume that if you have not heard back from the lab that they were able to work with it. Oftentimes you'll see a very small gray area that was not picked up, that did not turn blue. And my understanding is if it does not turn blue, it is not a large enough circumference, a large enough area that it needs to be rescanned. So I'm not certain if you're talking about a very small section or a very large section. Here's another question. With an exact copy of the intaglio, can you have a new digital denture made to change the occlusion from denture tooth wear? I would say minimally with the copy denture technique. I mean, the word copy really says it all. It is really a copy of that existing denture. The thing is you could always provide that scan and ask for, you know, a slightly different occlusal surface on the new denture and see what the lab is able to do. You know, it's a distinct possibility that you have enough data and the denture teeth are designed in such a way that they can replace that with teeth that are not as worn, are not worn at all, obviously, because they're new. Thanks. Thank you.
I'm going to enable the fill tool because we should be able to use the fill tool. However, we should all understand that it's going to take a minute. It's going to take a little bit. So if there's any other questions, please ask them now while we have the time.
Yes. So it's post-processing and going into the fill tool, and so the little hourglass is going to spin, and it's going to spin longer than what you are accustomed to seeing it spin in your office. And the reason for that, and trust me, we've done lots of testing with this, but the reason for it is because we're connected, like Brittany's scanner is connected via TeamViewer, which is a whole different sharing software, and then connected to Zoom, the platform that we are presenting over. So it has more lag time than what you would ordinarily experience. But the cool thing is that you can use the Zoom feature, or you can use the fill feature on the removable scans, which I think is amazing. I did a training yesterday and it was all on removables and activated the fill tool, and it's like, woo, woo. Makes me happy when it fills in. Now with this particular, and I've got the same denture here, right? With this particular denture, you can, let me see if I can do this trick. you can see like this intaglio area at the rugae right behind the centrals is deep. And the lens of the scanner can only get so deep, right? So when the fill tool is activated, Brittany's going to sort of like have to twirl it almost to get it to look in there, to get the light to shine in there. I'm not an iTero salesperson, so I don't remember the exact field of depth. I think it might be, I don't know. I don't want to misspeak. But all the scanners have limitations as to how deep they can actually view. So here's a couple chats. So if a patient comes in and loves the fit of their denture, but there's a broken tooth or doesn't like the shape of the teeth or the cant, which option in iTero would you use? I would probably use the fill tool for that. If the intaglio is great, if the fit is great, I would use the copy denture for that. Here's another one. Will the copy denture technique work if making a new denture due to a broken tooth, if it's only a broken tooth? I believe it should. I think that would be an appropriate option. You know, it's not all the teeth, it's just a tooth. Let's go up here. I think I got them. Oh, here's another one. But when using the fill tool, does it fill in the area not colored in blue? It's clear or gray. Yes, it should. So we will see here momentarily, but the area on the intaglio of that wash impression should encircle in red and be able to be acquired when Brittany goes back to scan it. Or that's been what my personal experience has been. Brittany, do you have an opinion on that one?
I've scanned this so many times, and each time I experience
it's a little bit different. It's a little bit different.
So seriously, it is. Sometimes there's enough anatomy where it'll I'm hoping it's going to highlight. I don't know if you can see my cursor. I'm hoping it's going to highlight the entire area, but I'm thinking it may not. I've got my fingers crossed over here. You just can't see it until now, but
we shall see.
You may be asking, why am I showing off the fill tool? Mostly because it helps us gather all the data that we need, right, in order to capture a good impression. But there isn't much to do under post-processing when we're done scanning, aside from perhaps take a screenshot. I could demonstrate if there's time. I don't know, we're already over a minute. But if you guys like, I'd be more than happy to demonstrate doing the screenshot feature, maybe putting in a note. Oh my gosh, you guys.
Go for it. So Brittany's going to start to scan right away, and I'm going to remind all the folks on here that have used the fill tool before and educate those of you who have never used it before that red encircled areas only stays on for a certain period of time, and then poof, it's gone. And there's not a hard number of how many seconds that stays activated is the language, that the fill tool stays activated. So once it's in circles in red, you be Johnny on the spot. You gotta go for it quick. Nice. Notice also that Brittany shifted it to stone model or monochromatic mode for scanning. Oftentimes, from a visual perspective, it can be easier for us as the user to focus in on missing data, especially with the crazy polyvinyl material I used for this. It was, you know, it was a project, it was donated. Pink and yellow, probably not my favorite colors to work with this on. And somebody had asked what kind of impression material it is. I do not know, and I would not necessarily recommend it. I think whatever heavy and light body PVS material you have in your practice and you're accustomed to working with would be more than adequate.
You know, guys,
Yeah.
we did our best, and it's not perfect, but we did it. I'm gonna hit post-process,
Okay.
which may take, oh, I forgot to do the bite. Oh my gosh.
I think you did fantastic.
Oh, thank you so much. I tried really hard.
Someone stated that they find the fill tool to be glitchy and better to go over the missing data. You know, I understand what you're saying. I think we've all experienced that. The thing about the fill tool is it is preventing you from over scanning and providing potentially poor data to the lab, especially when it comes to fixed work, right? Like it's different using it with the denture than it is for a crown prep. But look at that. Okay. So we've got the scan. Going to do the bite registration. And the bite registration is still going to be the similar process that you're accustomed to, you know, starting where the teeth interdigitate, going up to the maxilla, down to the mandible, back to where they interdigitate, and coming out a little W, a little wave, if you will.
Huzzah, now we can go to post-process.
Yeah. Great job. Several people said, great job. Are there any contraptions or MacGyver suggestions that will hold the denture while scanning? Ooh, I like that question. I'm of the MacGyver era. I like MacGyver stuff. I've not seen it. If you come up with something, Catherine, let us all know. My steady hand is the best thing I've experienced, and it takes a little something to get used to it. I've been in practices where the doctor has been trying to scan it and the assistant's like, give it to me. And they take it and they're much better. They're just steadier with holding the denture itself. Wear a blue glove and spray intaglio with Dr. Scholl foot spray. I have heard of the Dr. Scholl foot spray. Similar to, it is a type of titanium dioxide, if I remember correctly. So that would be similar to the Cerac spray. I've had offices use Occlude, you know, the green stuff we spray inside of crowns. What else? I think Brenda has taken articulation paper and rubbed like a certain area just to create a little bit of a distinction, as well as flowable composite, like a little squiggle, a little, you know, little squiggle of flowable on the cameo of the palate and tack it into place to scan that a little better. And so this is after post-processing?
It sure is.
All right. Do you
So
have
I can go,
yeah.
I was just gonna say, I can go ahead and demonstrate. I just want to be respectful of everyone's time. So if, I don't know if anyone said they wanted me to demonstrate the screenshot.
I do not see that as a specific request. So the screenshot is the little camera in the upper right-hand corner. Yeah, go ahead and do it. And thank you, being respectful of everybody's time. So while she is setting that up, have we ever worked with the prime scan for denture cases? I personally have not, but I know members of the team have. And again, every every scanner is a little bit different depending, and every patient is a little bit different.
What a horrible angle I did. But there you go. So
So
how
she
to
was
save
able to-
this is you go up to keep annotations. And then you can see down here, it'll save to the patient's My iTero account. Maybe if it loads.
Yeah.
And that's where you'll find that information. At this time, that information is not automatically sent with your scanned case, just FYI.
Dry shampoo. Somebody said that they've used dry shampoo. I think that would work well. I have not used dry shampoo. I mean, I use dry shampoo, but I have not used dry shampoo on a denture scan. So I like that. Place back in patient's mouth for bite. Yes, place back in the patient's mouth for the bite. That is correct.
And yes, we do have all the iTero series recorded. They're up on the YouTube page. Feel free to click that link, subscribe. You'll know right when this one is up and curated. And then we load them into our on-demand portal. So in case you have a colleague that needs some CE credit and some CE training, they can go into our on-demand site, which is nationaldentix.com/education, drop down on demand, and there's all the courses. So thank you everybody again for joining us. Sorry we went a little over, but exciting content, new information. And as you can tell, our wonderful iOS scanning training technology team loves to share what they know and help you improve your practice and your engagement with your patients.